Turki Al Fayea. Dr. Turki Al Fayea, he's a consultant of medical oncology in Princess Noura Oncology Center in King Abdulaziz Medical City in Jeddah. Dr. Turki is a well-known leader for lung cancer in Saudi Arabia. He will be discussing about maintenance immunotherapy and unresectable stage 3 non-small cell lung cancer over the next 20 minutes. So the floor is yours, Turki. Thank you. Turki, I think we cannot hear you.
You hear me now?
Yeah, we can hear you well. The floor is yours.
Thank you. Thank you, Dr. Shadi, for the invitation. I would like to thank the organizing committee for the invitation. So as Dr. Shadi mentioned, I will talk about the maintenance immunotherapy in unresectable stage 3 non-small cell lung cancer. So the stage 3 non-small cell lung cancer is, as you all know, not one disease. It's actually a heterogeneous kind of disease, ranging from small tumors to a very large tumors with a different level of involvements. And if you look at the guidelines for treatment, you will see that for stage 3, there are many options and many ways of treating this locally advanced disease, ranging from surgery in patients with N1 disease and found to have unforeseen N2, followed by adjuvant chemotherapy, and nowadays adjuvant targeted therapy, and possibly also adjuvant immunotherapy. And for patients with N2 disease who have a possibility of surgery, then majority of the time we consider the multimodality therapy, including the trimodality therapy. And for patients with N3 disease or for N2 that is not feasible for surgery, then we go for definitive chemoradiation therapy. So this is the area where the improvements happened in the last few years. If you look at this graph, you will notice that the survival in stage 3 was poor and still poor until recently, ranging from 9.8 months median survival in 1980s to 13.8 months in the 1990s and up to 17.7 months in the era of 2000. And this has happened because of some improvements in radiation techniques as well as the chemotherapy. So there were many efforts happened to try to improve the outcome in locally advanced disease. And one of them is the induction chemotherapy, but unfortunately there is no really good data to support the induction chemotherapy. However, in clinical practice, we use it in occasions where the tumor is a huge size and cannot be involved in one safe radiation field. And one of the efforts is the trying to use the consolidation therapy in locally advanced disease. So all the clinical trials evaluating the consolidation chemotherapy was actually negative, and there was no improvement in overall survival. And the consolidation used were the docetaxel, and cisplatin. There is also a trial of the pemetrexed as a maintenance. And also not just chemotherapy, but also the biological therapy like cetuximab were given concurrently with chemoradiation, and as well as the erlotinib and also the vaccine immunotherapy. And all of these failed really to show any survival benefit when it comes to overall survival. Also, multiple regimens used, carboplatin paclitaxel, platinum etoposide, platinum pemetrexed, and all of them really showed some benefit, but no good winner here. Maybe the most popular one used was the platinum etoposide, and also on occasions the weekly carboplatin paclitaxel has been used, and it is probably more safe with less esophagitis. So the standard of care here is actually the concurrent chemoradiation, and if you look at the median survival here is about 15% at 5 years. This is the overall survival at 5 years is about 15% with using concurrent chemoradiation therapy. And there were many efforts trying to increase the dose of radiation to see whether this will affect or not. And again, seems that the standard dose of radiation is as good as the high dose and actually associated with better survival. So until very recent, there was no really big difference, but the Pacific study was one of the trials that really changed the clinical practice, and it is one of the milestone trials in this field. And in this study, the patients with the locally advanced non-small cell lung cancer who were unresectable, who completed the definitive chemoradiation, including 2 cycles of platinum-based chemotherapy. They were randomized with good performance status 0 to 1, and they were randomized to either 1 year of durvalumab maintenance therapy or placebo. The randomization took place within 1 to 42 days post chemoradiation. So the primary, the co-primary endpoint were PFS and overall survival. So this is the initial report in 2017, and this was published in the New England Journal of Medicine. And you will see here that the median PFS was significantly in favor of the durvalumab, improving from 5.6 months for the placebo to 16.8 months for the durvalumab. The hazard ratio was 0.52, and I need you to remember this hazard ratio because in the follow-up trial, in the follow-up results of this study, the hazard ratio kept the same, meaning that the median meaning that the benefit from durvalumab was maintained. And this is the overall survival. So the median overall survival was not reached, but the control arm was 28.7 months for the median survival. However, at 2 years, there is really significant improvement in the overall survival with durvalumab, 66.3 months compared to 55.6 months. And you will notice here that the benefit was seen very early during the right away after the randomization. So the benefit from the durvalumab was very clear from the beginning. And the hazard ratio again is 0.68 for the durvalumab. This is the recent publication from the publication from the Pacific study. This is the updated PFS at 4 years, and this was actually presented in the ESMO last year. And you will notice that the PFS now is again the same, but the durvalumab median PFS was 17.2 months compared to 5.6 months. And again, you notice the benefit was maintained over time, and hazard ratio again 0.55. So very similar to the hazard ratio was reported initially at 2 years. This is the updated 4-year overall survival. And now we reach the median survival, 47.5 months, which is very impressive compared to 29.1 months for the placebo. Median, overall survival was maintained over time, hazard ratio 0.71, and which is similar to the 2 years hazard ratio. So there's no doubt that this study is very positive, and this is the updated overall survival and PFS based on the subgroup analysis. And it seems that all the subgroups, predefined subgroups, were benefited from the durvalumab when it comes to PFS or overall survival. So if we put all in perspective for the overall survival for stage 3, you will notice that over time, different publications and different meta-analysis, including different concurrent chemoradiation therapies, you will notice that the median survival improved from 12 months up to 29 months in one of the studies. However, for the Pacific study, it was 47.5, so almost doubling and tripling the previous publications. And the same thing for the overall survival at 5 years. It was ranging from 6 to 15%, and in one study 31%, but for the Pacific, the 4-year overall survival was about 50%. So putting all together, Pacific was really the best trial that we can get in this field of in this group of patients. And if we look at the survival by the stage, we all know that the median survival is going down when the stage getting bigger. But nowadays, we know that the subgroup of patients from stage 4 who have EGFR, who have a molecular alterations and treated with targeted therapies, or even the immunotherapy or immuno plus chemo, their median survival was actually ranging between 20 to 60 months. So it is really a paradox to find a stage 4 who lives longer than stage 3. But the Pacific study really changed or trying to change this fact by improving the median survival in this group of patients. Time to distant metastasis or death has been also published in 2018 in New England Journal of Medicine. So this study had 2 publications in the New England, and the median time to distant metastasis or death was 28 months for the durvalumab compared to 16 months for the placebo group. And the incidence of new lesions was significantly lower with the durvalumab compared to the placebo. And this includes many different organs, including also the brain. These are the adverse events. So generally, the interest or the adverse events of interest is the pneumonitis, and the grade 3/4 pneumonitis was 3.4 for durvalumab compared to 2.6% for the placebo. So generally, the immune-mediated adverse events were 24% with durvalumab compared to 8.1 months. But as I mentioned, the pneumonitis is 3.4% grade 3 or more. There was a publication about the quality of life, and you will see here that there were different domains evaluating the quality of life, including the global health being, the physical functioning, emotional and cognitive functioning, and also different other symptomatic domains. And you will see that all of them are in favor of the durvalumab. So generally, the patient-reported quality of life was really comparable between the 2 groups. So this is not just for the durvalumab. There is also a efforts to try to use different immune checkpoint inhibitors in the consolidation part. This is a trial, phase 2 trial, evaluating the pembrolizumab as a maintenance therapy from the Huzair Cancer Research Network. The difference here is that this is a phase 2. The other difference is that there are a large number of patients with stage 3A, 60%. And the other difference, the consolidation started a little bit late compared to the Pacific. So the start here was about 4 to 8 weeks since the radiation, last dose of radiation. So looking at the distant metastasis, you will see that the median time to distant metastasis is at 30 months, which is very similar to the Pacific. But the median PFS and median overall survival were lower, 18.7 months for PFS and 35 months for overall survival. Definitely, they are lower than what has been noticed in the Pacific, but they are better than what has been reported from other concurrent chemoradiation trials. So this is a very promising drug in this field also. Another study, phase 2 non-randomized study, the Keynote 799, which is again a pembrolizumab evaluated in this group of patients. So if you look at the study population, they are very similar to the Pacific. And in this study, the pembrolizumab was given for 1 year. And the first cycle was given concurrently with chemotherapy, either paclitaxel carbo in a cohort A that include all patients, or in cohort B that include non-squam. So the pemetrexed was given only here. And the subsequent second and third cycle of pembrolizumab were given concurrently with chemoradiation. Then maintenance pembrolizumab. So you notice the primary endpoint was actually 2 primary endpoints were response rate. The other primary endpoint or objective was the percentage of patients who develop grade 3 pneumonitis. So response rate in both cohorts was in the 70% for both cohorts. And the response was very similar across all the groups, irrespective of PD-L1 status and irrespective of histology. So pembrolizumab is really promising in this field. Grade 3 pneumonitis was 8% and 7.9% in cohort A and cohort B, respectively. And this is the median PFS. The median PFS was not reached for both groups, but the 12-month rate was 67 and 65% for both cohorts, respectively. And for overall survival, median was not reached, but the 12-month survival rate was 81% for cohort A and 88% for cohort B. So again, pembrolizumab is really having anti-tumor activity here, irrespective of PD-L1 status. This is another effort of the nivolumab use as a maintenance, and this is from a small trial including 79 patients, the ETOP-Nicolas study. And in this study, the difference here is that they give actually, as the Checkmate 799, they gave 3 cycles of nivolumab concurrently with chemoradiation, followed by 1 year of maintenance nivo. And we know the primary efficacy analysis was published recently. The 1-year PFS was 53%, median PFS was 12.7 months. And the difference here is that the pneumonitis is really high, 10% or more for grade 3. And also the treatment adverse events was 18% for nivolumab compared to 9% for the radiotherapy. So if you put this study in perspective with other trials, one of them is the Keynote 799 that we discussed in the last few slides, and also the deterred trial, which is a phase 2. If you look at this study, the atezolizumab was given concurrently with chemoradiation, followed by adjuvant atezolizumab, and the pneumonitis was more than 10%. And for the Keynote 799, the patients were given concurrent chemoradiation plus pembro, plus adjuvant pembro, and the grade 3 pneumonitis or more was 8 to 10%. So this is something to put in your mind, that immuno plus chemoradiation probably effective, but the rate of pneumonitis is maybe high. So a few points about the Pacific. Number one, we ask ourselves, does Pacific represent the general population? I think the simple answer is no, because we always find in a large randomized trials, the patient selection is very good, and sometimes, majority of the time, do not really represent the real life patients. For example, if you look at the baseline characteristics here, you will see that in Pacific, there was more than 50% had stage 3A. They carry better prognosis generally. And also the performance status 0. So 50% or more had a good performance status. So to start with, they have a very good prognosis patients. If you look at the other locally advanced clinical trials, stage 3A is definitely lower, and PFS and PS 0 is 40 to 50%. So they include a good patients to start with. This is a real world data from China of durvalumab maintenance. And again, majority of their patients, although in this study, the patients were only 60 patients, but the majority here were actually stage 3B and C. And in this small study, only 55% were able, 45%, were able to meet the Pacific criteria, and 55% could not meet the Pacific study criteria. So to really have a better image about the Pacific, this is a real world Pacific study called Pacific R, and it is an international observational study. And you will see here the earlier safety data coming out, and you will notice also patient characteristics. You will notice that there is about 15% in this study did not receive concurrent chemoradiation. They were actually treated with sequential chemoradiation, and which is something that we see every now and then in our clinical practice, where patients cannot go for concurrent chemoradiation because of comorbidities or contraindication to chemotherapy, or bigger tumors that cannot be cannot be treated with radiation. So 15% treated with treated as a sequential, and there was only 35% in this real-world study or a real-life study were able to receive durvalumab within 42 days. And so the majority were not able to go for the treatment as planned by Pacific. The median time to start durvalumab from the end of radiation was 52 days. The other question, do we have a predictive biomarker from this study? So we know that the PD-L1 testing from this study was not required. They were actually 37% of the randomized patients do not have a PD-L1 or having unknown PD-L1 status. And the PD-L1 status was determined from the tissue pre-chemoradiation. So getting the sample post-chemoradiation is medically not feasible. And the PD-L1 cutoff of 1% here was actually part of the unplanned post-hoc analysis requested by EMA. So generally, the the benefit from durvalumab was seen whether patient had PD-L1 high or low, and seems that the post-hoc analysis here is showing the no benefit in patient with less than 1% PD-L1. In any event, the FDA approved it irrespective of the PD-L1 status. And in many areas of the world, the durvalumab has been approved irrespective of PD-L1 expression. Now, moving forward, is there any way to improve the outcome in this locally advanced disease? So there are many options or many areas of research. The first one is to improve the timing of start of IO, meaning that can we make it more closer to the radiation? Can we combine it with radiation? Can we even use the IO as a new adjuvant? And the other question is optimal duration. We don't really know whether maybe more than 1 year is better than just 1 year. And we have a experience from the adjuvant EGFR TKIs where the more duration probably is better. So optimal duration was not addressed yet, or at least we don't have published data on it. And also the regimen itself. Can we combine IO with the platinum and radiation? Can we give it just radiation with IO? Can we just give IO and IO with radiation? So, or maintenance? So these are all open areas for discussion. If you look at the radiation, when you give radiation, you are actually stimulating the dendritic cells to pick up the antigens and to stimulate the effector T cells. So these are the best time to give radiation, to give immunotherapy is really to give it very close to the radiation. And we have data from the preclinical models where the murine tumor cells are expressing more PD-L1 on the days of radiation therapy. And also, if you look at the survival for the murine model, you will notice that the best survival has been achieved when radiation was given with monoclonal antibodies against PD-L1. And we have also data from the Pacific subgroups. The patients randomized and received durvalumab less than 14 days from last randomization, from last radiation, showed a significant survival benefit compared to those who had a durvalumab more than 14 days. So the closer is better. And this will also address or at least answer the question of the concurrent immunotherapy plus chemoradiation. This is ongoing study of a Pacific 2, so very similar design to the Pacific. The difference here is that they added durvalumab plus chemotherapy and radiation therapy to see whether this approach will have a better outcome. How about the sequential chemoradiation? As I mentioned before, the sequential chemoradiation, we use it sometimes in patients who cannot go for concurrent chemoradiation. So the Pacific 6 is a phase 2 study evaluating this approach. So give sequential chemoradiation followed by maintenance durvalumab. The earlier outcome here is telling us that it is very feasible. If you look at the time from radiation to durvalumab, less than 14 days was 100%, meaning that all patients who had a sequential chemoradiation were able to receive durvalumab within 14 days of last radiation, meaning that the sequential chemoradiation is not really tough and will allow patients to get the durvalumab earlier. So as I mentioned, the timing is very important. Maybe new adjuvant IO will be better, and we are waiting at least for the full publication from this study that used atezolizumab as induction, so given 2 cycles. Then if patient having a stable or responsive disease, then 2 more cycles of atezolizumab followed by concurrent chemoradiation, the maintenance atezo. And if patient had earlier progression on atezo, then the patient will go right away to the chemoradiation. So disease control rate at 12 weeks was 77%, very encouraging. Response rate was 30%. And finally, the 1 year or 2 years or more than this, we don't really know, but at least there is ongoing trial, Gemstone 301 trial. This is a trial evaluating this monoclonal antibody, CS1001. This is a monoclonal anti-PD-1 antibody that has been invented and tested in China. And this is a trial evaluating the similar group of patients for the Pacific. The difference here is that the randomization was for 2 years of the CS1001. So we have to wait to see whether more treatment will be better. And finally, the question comes, can we just drop the chemotherapy, give radiation therapy with immunotherapy? At least from the previous discussion, we know that maybe it's effective, but pneumonitis risk is high. But at least we have 2 trials, small number of patients in both trials, using durvalumab with radiation therapy. And in this ARCON trial, they included only the PD-L1 of 50% or more. And these are the data to assess whether nivolumab as a maintenance is good, or nivo plus epi maybe better options. So to conclude, the consolidation immune checkpoint inhibitors are practice changing. Durvalumab has impressive PFS and OS data with manageable toxicity. All eligible unresected stage 3 non-small cell lung cancer who completed concurrent chemoradiation therapy, including cisplatin or carboplatin-based therapy, should be offered the Pacific regimen. And the best patient population who will benefit are not yet defined, and there is definitely no specific predictive biomarker so far. And there are many ongoing trials evaluating the other strategies, for example, timing of IO regimens used, and also duration of IO therapy. These may really further change the current practice in the near future. Thank you.
Well, thank you, Dr. Turki, for this nice review. And I believe we'll leave the question until the end of the session. So with this, it will be my pleasure to introduce our next speaker, Professor Julian Molina. He's a professor